Declan, it's cold.
It is freaking cold.
My goodness. Madrid in March, almost April.
I know.
Who would have thunk it?
And this is, what is it, day 3 of the EAU, and this is actually, we wanted to do the intro from outside.
We did.
But the weather's been so terrible. We had to wait till day 3 till it actually cleared over, and you still have to wear a coat. Nice coat, by the way.
Yeah. I had to borrow it from Elena Castro. Elena, thank you.
That's Elena Castro's coat.
That's Elena Castro's coat.
You didn't bring your winter woolies from Melbourne to Madrid for the meeting. Yeah.
But the one good thing about the rain and the cold is that everyone's been inside enjoying the amazing scientific content at EAU 2025. Maybe they planned it that way.
So that's where we are. We're here at the EAU Annual Meeting, my single favourite general urology meeting of the year, and it's in Madrid, and it's awesome to be here. Thanks again to our gold partners, Bayer China, who support not just our main podcast, but also specifically our conference highlights. And we will be tracking down some Chinese colleagues here, actually. But yeah, we've had to wait till day 3 to do the intro because it was unbelievable. So deluge. Madrid's never seen anything like it, and it's been cold, not just wet. It was like freezing cold. So it is picking up now, thankfully.
And it is a favourite meeting for a reason. It's a big meeting with still a small meeting feel. We've caught it with a lot of our colleagues. The EAU guidelines, are the most popular, the official guidelines in Australia. So it really is wonderful to be here and get the latest data. And there's been some good ones.
Yeah, and if you're watching on YouTube, we're kind of on the street that runs down the middle of this gigantic conference centre. It runs for kilometres and kilometres.
20 minutes to walk from one side to the other.
It does, and EAU doesn't take the whole of it. I don't know how many people, 10 or 15,000 people at this conference, but regular viewers might recognise this view actually, because I remember being at ESMO here a year and a half ago, recording from here as well, and there are like our 40,000 delegates at ESMO. They take the entire thing. But it's a fantastic place to have a conference, and there's some really good stuff already been happening here. So as ever, we're going to bring you a flavour of the meeting, and we'll try and track down some people. And of course, we've already pushed out those 2 podcasts from 2
game-changing plenary talks that we've highlighted in 2 separate podcasts. So that's that, and they were huge, weren't they? Yeah. Both in the Lancet Oncology and really practice-changing, I think.
The Translate trial and the NeuroSafe trial. We'll put the links in this show as well, but they deserve their own podcasts, and we dropped them during the meeting. But as you're watching or listening to this, it's a couple of weeks later probably. So we have already tracked down a few people. Yeah. We'll track down a few more. We parked ourselves at the European Urology stand, which was quite handy, wasn't it?
That's right. Yeah, well,
and you'll see a bit of that. Home. And David, our erstwhile videographer from Melbourne, is here with us. David is behind the camera, and he's been here all week. He's a recently graduated doctor. He's been part of our research team for a while, but it's hard to believe he's only just graduated. So thank you, David, for being with us, and let's go and see what we can do.
We've got more work to do, so let's go.
Let's go. At the EAU after another of the big practice-changing plenaries. We've already posted 2 separate podcasts from the EAU about practice-changing plenaries, but there was another really important paper presented this morning.
Indeed, yes, by Laurie Klotz, who's right here, and Caroline Moore was the discussant.
Yeah, great. So Laurie Klotz, welcome. Professor Laurie Klotz from the University of Toronto. Great to have you back on the podcast. And Adam Kinnaird from Alberta, Canada, University of Alberta. And well, congratulations to both of you on the OPTIMUM trial that you presented today. A great achievement reading out here, and a big paper in JAMA, same time.
Yeah, thanks, Declan. Yeah, so microultrasound, fairly new technology, maybe 7 or 8 years old, and it's based on 29 megahertz, which gives resolution of 70 microns, which is about 3 times greater than the 200 micron resolution with conventional ultrasound. And the reason it's a very significant advance, I think, is because 70 micron resolution means you can visualize changes in ductal anatomy, which is essentially the same principle as restricted diffusion with MRI. So there's now about 80 studies in the literature, mainly registries or single center studies, that have shown the detection rate for significant cancer is about the same as with MRI, but it was all really level 2, 3 data. So this study, which has just been published today in JAMA, Adam is the first author.
Oh, congratulations, Adam.
This study was an attempt to develop level 1 evidence to demonstrate, it's a non-inferiority study, to compare high-resolution microultrasound prior to biopsy to MRI prior to biopsy with fusion targeted and conventional ultrasound. And then the third arm is the combination.
So fantastic. So the background being, of course, MRI has become a standard of care for early detection biopsy-naive men, but lots of limitations, aren't there? We'll all accept that not everybody has access to high-quality MRI, it's not always funded, and so on. And I've been watching you for years show these beautiful images of micro-ultrasound, and they have been stunning. This 29 hertz probe does produce beautiful images, so it's always been an interesting and tantalizing idea to say, well, is this going to be as good at localizing these lesions as we've got used to with MR? And so that was the intent, to produce a high-quality, randomized data set of biopsy-naive men, including MR as one of the three arms. So OPTIMUM trial, and so tell us a bit more about what you told us today, or maybe a little bit about those three arms, I suppose.
Well, I'll hand it over to Adam.
Okay, sure. Adam, great.
So this study was beautifully designed. It was a three-arm trial, which is a little bit different than usual for a randomized control trial, but what this allowed us to do was test both the primary objective and the secondary objective against the same comparator group. And so the three arms were one arm of micro-ultrasound only, so no MRI. Then there was the comparator arm, which was MRI only with conventional ultrasound and a fusion-guided biopsy. And then there was a third arm, and that third arm was a group of patients which had micro-ultrasound first and an MRI, or they had an MRI first, but the operator of the biopsy was blinded to the results of the MRI while they did the micro-ultrasound targeted cores, and then they were unblinded to the MRI, took any MRI targeted cores that were missed by the micro-ultrasound, and then finished up with the systematic biopsy.
Fantastic.
Yeah, and so what we found, the way we were able to do the analysis is we were able to compare the arm that was micro-ultrasound only with the blinded portion of the micro-ultrasound MRI arm, and come up with a 50-50, a one-to-one randomization basically, or split of the patients with micro-ultrasound only data to MRI data. And what we found is that micro-ultrasound guided biopsy was non-inferior to MRI guided biopsy. And in fact, when you look at the absolute numbers, micro-ultrasound guided biopsy found clinically significant prostate cancer, which we defined as grade group 2 or more prostate cancer in this trial, 46.1% of the time, versus in the MRI guided arm, it was 42.5%. So there is actually an absolute increase, but as the study stopped early for success, we couldn't show superiority, but we definitely showed non-inferiority, which was the primary objective of the study.
Wow, so it introduces a whole potential new paradigm.
That's right.
It's not to say we should drop an MRI targeted pathway. It's still supporting the idea of a targeted pathway, etc., for men, and but it does introduce a new alternative, I suppose, Renu.
Yeah, but Laurie and Adam, one other advantage of an MRI is we can really select who we biopsy, because Laurie, you're the father of active surveillance. We really don't want to increase the diagnosis of insignificant disease. So in your study, how did it perform with, compared to MRI in the diagnosis of insignificant disease? Did you find that increased?
So what we found is, now with the caveat that every man was biopsied in this trial, so no man avoided biopsy, but we did not find we didn't find really any difference at all in the amount of grade group 1 that was detected in any of the arms. But that is with the caveat that all men are being biopsied. Now there is another trial that is just starting right now called MUSIC Screen, Micro-Ultrasound in Cancer Screen, where what we do is, this again is going to be an international multi-center study with many of the same investigators plus some new additions, where men will get randomized to MRI or micro-ultrasound in a 1-to-1 ratio, and if the imaging is negative, then they will avoid biopsy. But if the imaging is positive, that's when they'll go on to a targeted and systematic biopsy, with the primary outcome being the detection of clinically significant prostate cancer, and secondary outcomes being the detection of clinically insignificant prostate cancer.
There was no difference in grade group 1 diagnosis rate.
Yeah.
The other analysis we did was looking at targeted biopsies alone, leaving out the systematic, and also showed exactly the same results for grade group 2 and higher, grade group 3 and higher, essentially non-inferiority.
So I think for those primary endpoints of cancer detection rates, this really performs very well, hence practice-changing plenary today and JAMA paper. A question that came up with you and with Caroline in the discussion is, what is the learning curve with this, or intra-reader variability? If we got one of these micro-ultrasound machines tomorrow, Laurie, could I just pick it up and have a crack, or would have to come and spend a few months, or have an expert person like you do it?
Yeah, so a few things about that. So for sure there's a learning curve.
Yeah.
There is data on this. The learning curve for urologists who are used to doing conventional ultrasound is short as 15 to 20 cases. We think it's more like 40 to 50 cases to develop reasonable competence, and probably closer to 100 to become really highly competent, I would say. It's easier than MRI. There's no question. You only have one parameter. You're not trying to integrate the results of multiple parameters. You know, it does put the diagnostic onus on the urologist. So, you know, this is not something where you can do, you know, a couple of cases a month. You have to, it's like anything else, you know, you have to be committed to it, develop the expertise, and because you're taking the responsibility, particularly if you do, as I do, only targeted biopsies. I've pretty much stopped doing systematic biopsies. That's kind of a controversy at the moment. But if you're only doing target biopsy, you got to be damn sure in your own mind that you're not missing a target.
Absolutely.
So, but really, I've found personally, it becomes quite quick to be able to look at these things. After a while, the abnormalities just stand out like a headlamp, like a headlight at night. You see it immediately. And so it also, I would say, is not, it's not really a very time-consuming procedure to do it all.
Because the difference is the probe. You're going from like 7.5 megahertz probes to 29.
Yeah.
So, and it's otherwise the probe roughly the same size as a regular probe.
It's the same. Now, the probe is something special.
Yeah.
So, the downside of higher frequency is lower depth of penetration. So the company has dealt with that by basically packing about 3 times as many transducer crystals into this probe as on a normal probe, but the dimensions are the same. But you know, these probes are really something special, and that has allowed the depth of penetration to go up to 6 centimeters, which is pretty decent. I mean, you can visualize the entire prostate in just about all patients, except the guys who just have massive prostatomegaly. Yeah.
Adam, if microultrasound becomes more widely used, do you see it having a more standardized way of classifying these lesions or standardized reporting?
Yes, absolutely. So right now, the analogous reporting system is called Primus, which is analogous to PIRADS. And of course, something that I think is really important is that this system is only in its first iteration, it's version 1, whereas PIRADS is in multiple iterations. And so I think that what we can go back and look at the data set, and one of the nice things from this trial is that all of these images are stored in a central image repository. We can go back, and every time you take a biopsy sample, you save an image, and it saves basically the last 10 seconds of what the image, of what you were looking at. So we can go back retrospectively and say, okay, that image that we said was Primus 3 was actually cancer. This one that we said was Primus 4, that is a starry sky appearance, was actually inflammation. Maybe we should revamp and come to a version 1.1 or 1.2 or 2.0 for Primus, and basically improve sensitivity and specificity of the Primus score.
And Laurie, one of the other things that's come up at the EAU is transperineal versus transrectal, that the Translate trial read out, but I think 40 or 50% of the patients in the trial had transperineal, so that's not a limitation as such. You know, if there's a swing, or if your preference is transperineal, you can still adopt a microultrasound in your practice.
We didn't specify, and the same was true for the technique of fusion targeting. I mean, we basically wanted this to be kind of, as much as possible, a real-world study, so each center, whatever they were comfortable with, transrectal, transperineal, whatever fusion targeting system they used, that's how it was done. We do have data that the MRI interpretation was high quality. The predictive value for PIRADS 4 and 5 was very high, like over 85%. And just before our study was the another study, transperineal versus transrectal, which showed randomized study, which showed a 5% higher diagnosis rate with transperineal. So to my mind, that's to be the final brick in the coffin, or nail in the coffin of transrectal. Not only less infection, no need for antibiotics, but a higher diagnosis rate. Like, what more do you need?
Yeah, exactly.
Absolutely.
And finally, so are these machines, they're commercialized now, or is there one provider? I know you said there's separate health economics and stuff coming, but what is the rollout? This is a big paper now, practice-changing plenary, so if people are asking the question, and especially those people, I suppose, who don't have good access to MR or don't have funded MR.
That's the real appeal. Yeah, it's one company, it's a Canadian company, but they have worldwide distribution now. They are all set to ramp up big time.
Yeah. What's the name of the company?
It's called Exact Imaging.
Exact Imaging, okay.
And I understand, because I've talked to the president about this, that their capacity to meet the demand should not be an issue. Okay, great. So yeah, and the cost is comparable to basically to a high quality normal ultrasound. It's like any of these technologies, it's not cheap, but it's dramatically, at least a log cheaper than an MRI machine.
Congrats.
Very good. Congratulations to both of you. What a big deal this is. JAMA publication, huge game-changing plenary, and we can't wait for more.
And
thank you.
And we'll put a link in the show notes to that trial as well. But congrats and thanks for joining us, Adam and Laurie.
Pleasure.
Okay, so here we are with one of our favourite associate editors of European Neurology, Sarah Psutka. Sarah, great to see you.
So good to see you, Renu. Thank you so much.
How's the meeting been so far?
It's been exceptional. This is one of my favorite.
You're not talking about the weather, right?
Yeah.
There's sun out today. We're going to. I'm from Seattle.
This
is
Seattle.
Great. I'm enjoying this. I worry I brought the weather with me. No, it's been so great. I mean, this is an unbelievable meeting. This program has been, hats off to the scientific committee because it's really been exceptional. I think there's been a ton of engagement. It's just such innovative work, and everyone is really, I think, pretty excited about the novel data that we're seeing, but also just really thoughtful discussions about sort of best management practices for our patients.
Yeah, and I think the way they've structured this conference is really nice. Those abstract sessions and then the plenary sessions are really well thought out. Each talk kind of rolls into the other really nicely. There are some great questions from the audience. It really is a big meeting, but has that small meeting feel.
Absolutely. No, and I think it's been great to see every day there's been so much engagement, which is just really, tremendous. And from, across all the fields, it's really exciting.
Bladder cancer, Declan, let's talk about that.
Let's talk about bladder cancer.
Yeah.
Every time we talk about bladder cancer, the ratings go through the roof. We clearly don't talk about it enough, but you're a bladder cancer expert, and today I saw you were presenting an uprise on Sunrise 4. The whole Sunrise series of trials are very interesting, the whole TAR 200 thing. Yeah. Maybe for people who have no idea what TAR 200 is and what Sunrise trials are, can you just give us what are the Sunrise trials and tell us a bit about what you presented this morning? I saw Shilpa Gupta and others tweeting about it, so there is excitement about sharing that data.
Well, so just the Sunrise program writ large is looking at this novel device, which is the TAR 200 device, which is a chemotherapy-eluting device that's placed in the bladder. It's exchanged at set intervals.
It's like the pretzel thingy, is it?
Yes, but we're not supposed to say pretzel.
Are we not? Okay.
The neat thing is it promotes sustained release of cytotoxic chemotherapy, so it gets away from the problem of intravesical washes, where you really have very limited contact time between the chemotherapeutic and the bladder wall. There's also, this was not something that I presented, but there was I'll just give a shout out to another presentation that happened at the meeting, which was the Penelope project, which is just some preclinical data basically demonstrating that not only does putting this device in the bladder expose the innermost lining of the bladder to the gemcitabine, but there's actually transmission of the gemcitabine through all layers of the bladder wall, and it's sustained in its exposure. And this was an animal study that was presented earlier in the meeting. So really, really exciting, very, very compelling preclinical data. We obviously have the indication in the United States for BCG unresponsive non-muscle invasive bladder cancer, but the Sunrise 4 project, which is what we were talking about, this was an interim safety analysis. So Sunrise 4 is specifically looking at for patients who are muscle invasive but cisplatin ineligible or cisplatin refractory. So can't give them neoadjuvant chemotherapy. What can you do to try to reduce the risk of recurrence and improve survival? So for these patients, the study is set up, it's a randomized trial. Patients are randomized to either get citralumab, which is a PD-1 inhibitor, or citralumab plus the TAR 200 device for 12 weeks before cystectomy. The outcome of interest is pathologic complete response. Andrea Necki presented that at ESMO. I'm sure you guys probably talked to him about that. And so, interestingly, in the interim response, the first interim analysis, 76 patients, we saw a doubling of the pathologic complete response in the combination arm. So the other thing, though, is if you're going to have a neoadjuvant therapy strategy that's new, you've got to prove it's safe, you've got to prove it's tolerable, you've got to prove that it doesn't prevent patients from getting to surgery. And so that's what we were talking about here with surgical outcomes. So we basically demonstrated similar complication profile in the post-operative setting compared to what we see historically. We saw that there wasn't a delay to surgery in either the combination arm or the sertralimab monotherapy arm. So with TAR-200 plus sertralimab or sertralimab, median time to cystectomy was 13.5 weeks, which over 88% was within the protocol specified window. And so we showed essentially it's safe. You can do it without delaying time to surgery. And we also showed that it didn't change performance status, which obviously is a major issue with cytotoxic chemotherapy. So early data, very exciting. I get to work with Andrea Necki as the global co-PIs for the study, which is very exciting. The study's fully accrued. We expect to see the results in the coming years. But very excited about everything that's happening in bladder cancer right now, but especially this.
Amazing, isn't it? And congratulations to the whole team.
I just saw another bladder cancer expert walking by. Is that Laura Bukavina? Laura!
Come on in.
Come on in. A proper friend of the podcast as well.
She's just returned from Australia.
Yeah. Didn't we just see you in
Straight
Australia
to
a couple of weeks
Madrid.
ago?
You did? I did. I came for the koalas mostly.
She was surrounded by
my
fluffy
God.
little quokkas and koalas and kangaroos. We couldn't really see her face.
Well, here we are, Renu.
Yes.
With
Two big
Laura
bladder
Bukavina
cancer
and
experts.
Sarah Psutka, two of the favorites on the podcast, but two of the world's leading experts on bladder cancer.
Yeah.
And wow, great to have you on. We were only talking about bladder cancer in Australia a couple of weeks ago on the podcast.
Yeah, we have. We talked about ctDNA and how it's changing everything. And de-escalation therapy. That's the
And you
name
did
of the
that
game.
great debate up against one of our medical oncologists about bladder sparing. Yeah, everyone's still talking
That was
about
a
that.
tough room for the medical oncologist. It was all urologists. It was unfair.
Hey, we've just had a great update from Sarah about the Sunrise 4 data she presented, the TAR-200 thingy. Hey, by the way, why aren't we allowed to call it a pretzel anymore? I'm a simple prostate cancer guy. Is that like an industry thing? Because it's not a... Or in case we would put pretzels in the bladder.
We call it a device.
Okay, a device. Okay, but I love the pretzel thingy, but okay. Anyway, so
Pretzel and
sorry
thingy,
to all the
both
bladder
out.
cancer
It's a device.
experts, but what's your take on these devices? Because they, the whole way you introduced it, Sarah, that it gets over the limitations we have with trying to shove stuff into the bladder for an hour or two and come out. But these devices look semi-revolutionary, don't they? There's all sorts of different things, like non-oncology things, I suppose, you could be using to have a prolonged effect over a while. And,
I think it's the concept of what's next is more exciting to me than the current, what are we doing now? So I think one medication is great. We know that generally cancer tends to become resistant to one medication. So, but I think the concept and the technology is very exciting, and things that we can put on it, and what's next, what's coming. What are we going to be doing for you? What are we doing for prevention of recurrences?
But I think there is a what's next already in process.
Yes.
So I'm sure you've heard of the Moonrise trials, which are using erdafitinib, which is an FGFR inhibitor. And so that's the idea: is can you start to put different devices and promote sustained release in a tolerable fashion, in a way that we can't do it with clinic visits. So it's interesting. It's certainly, I mean, now we're getting at sort of biologic basis and pathogenesis. Can we actually interrupt that much more specifically, which is really exciting.
And logistically for patients, it's incredibly much easier for them. And economically speaking as well, in terms of the volume of nursing time that you can save just based on these devices, it's incredible.
I find the pathological complete response rate really fascinating, and we saw a little bit of data that came out of the Niagara trial as well. I mean, do you see devices like this, especially in combination with systemic immunotherapy, are there going to be a subset of patients that can avoid cystectomy?
Well, I think that's kind of the holy grail, isn't it? Like patients are asking us for the opportunity to get to the point where they don't have to have their bladder removed. We're not there yet because we still don't actually have a great way to adjudicate clinical complete response, not pathologic complete response. We need to know that not only is there no cancer in the bladder, we need to know there's no cancer anywhere. To your point with the ctDNA, we're probably going to start to see these novel biomarkers really help us with that, but at this point we're not there. But I think that is the question. Can we not only get to that point, and then the big question is, can we identify those patients correctly? So.
And the other thing, Sarah and Laura, is that these systemic therapies are toxic, I mean immunotherapy, and maybe you've looked at it in one of the Sunrise trials, but have you looked at just TAR-200 on its own as a neoadjuvant option?
As a neoadjuvant option, it has not been evaluated in muscle-invasive bladder cancer as a neoadjuvant option. It's, of course, the initial sort of proof of concept first in human studies that were done and published now a couple of years ago looked at using TAR-200 in patients with muscle-invasive disease who were precluded from going through surgery. They're not surgical candidates. And there's the whole sort of TAR-200 portfolio that's looking at it in all of the different sort of disease spaces of bladder cancer. So I think from a safety perspective, that data is published, that it is relatively safe, it is well tolerated. The primary side effects are urinary urgency, frequency, and urinary pain. And certainly the patients that I had on trial experienced those, but as urologists, we're pretty good at being thoughtful about handling those side effects. And we do have, I think, sufficient at this point. We'll actually be publishing a toxicity management sort of manual in the coming months, which I think will help physicians be able to manage those side effects for their patients in a way that makes it tolerable. And we didn't see a lot of patients coming off trial because they couldn't tolerate it, which I think is reassuring.
Yeah.
And Laura, any other bladder cancer highlights here in Madrid? You've been involved in a lot of sessions. I keep seeing your name pop up here and there.
Everywhere.
I've been stuck in the purple room 1, which is all, basic science, but I think there's a lot of work in ctDNA increasing sensitivity. So Lars's group has talked a lot about really pushing the sensitivity and using both tumor agnostic and tumor sensitive approach. So there's a lot about talk about that. There's a lot of talk about urine ctDNA and how we can incorporate it into actually picking out the patients who are, as Sarah said, is not just clinically T0, but really being able to understand that translate into PT0 combination of ctDNA and urine DNA. Lots of translational things are working towards the same goal as a lot of the clinicians are working in terms of the trials.
Awesome.
Fascinating. And Sarah, now tomorrow there is a very unique plenary session, the prehab session. Tell us about that.
Well, this is a topic that's near and dear to my heart. I mean, this is my favorite thing to talk about. So
Her face just lit up.
I know.
I remember she did an amazing plenary in Australia a couple of years ago, jaw-dropping to me.
I love getting people fit. It's my thing.
Yeah.
But no, I'm so excited. So it's kudos again to the scientific committee for being really thoughtful. This is one of the first times that this topic has ever gotten a plenary spot, and the fact that we are gaining traction and people are really talking about ways to incorporate, and I'm going to even move kind of beyond prehab, and that's the way my brain is now thinking, is really it's about perioperative optimization. So it's not only getting people ready for surgery, but then also facilitating active recovery. How do we integrate exercise, nutrition, mindfulness-based practices, stress minimization, all of those sort of supportive care adjuncts into holistic, comprehensive cancer care. But how do we do it pragmatically? How do we do it without reducing treatment burden? How do we do it without reducing financial toxicity? How do we do it so we actually get what we're hoping to get out of it and train to the test and see real scientific results? And I think we're starting to see some really exciting trials that are demonstrating that we can move the needle for these patients. And then the big thing, like I'm going to be talking about tomorrow, is how you can do this even in patients who are not getting surgery but might need surgery someday. So really excited. There's just a wealth of expertise on the stage tomorrow. People like Jim Cato, who have been leading the charge in this for years. And I'm really excited to have that conversation and have the opportunity for people to kind of hear what's being done in that world.
Absolutely. It's going to be amazing.
Great.
And I think that prehab is not only just important for, like Sarah said, for cystectomy, right? In patients who are considering bladder preservation or TMT, or even potentially our metastatic patients undergoing chemo, a lot of the same concepts can be applied in those patients because they do tend to, they grow weaker with each systemic therapy.
And it's not in a back room somewhere, it's in main plenary tomorrow. As you say, well done to Martin and the scientific
congratulations.
committee.
Very exciting.
Yeah, well, and to your point, I'll give a little plug. We're very shortly going to be opening the Empower study, which is a phase 2 trial of prehab, a personalized exercise delivered at home in patients with non-muscle invasive bladder cancer. We just got funding for that last week, so we're really excited to actually, thank you for alley-ooping that.
There we go. And the great thing about this, Declan, is that, what they're doing here can be applied all across the board to
It's
so many diseases. It's not just cancer.
Older patients. It's
Yeah.
not just patients who are having surgery.
Absolutely.
I mean, frankly, we all need it.
Yeah, anyone.
I need to do it before the conference every morning.
Well, look,
my way here.
and both associate editors on European Urology, and that's where we've been camping for the week here. So,
Yeah.
and it's been an awesome week for European Urology. We had great chats with Bergh and Eoin co earlier on as well. So, look, thanks so much for popping in.
Let's go get ready for the ball.
Yeah, ball
Yes.
tonight. Yeah,
Yes.
going to the ball.
Got my Cinderella dress on.
Oh, very nice.
Wonderful.
And Sarah?
Looking forward to
I
it.
do remember Sarah one year wearing the dress that she wore at her wedding. Is that right?
True story.
I don't have very many dresses.
Well,
was a
we
keeper.
might pop up a picture of some of the glamour at the ball tonight then on the podcast. So thank you so much.
Thank you. Okay, so here I am with European Urology Oncology Associate Editor Riccardo Campi. Riccardo, welcome to GUcast.
Thank you very much, Renu. For me, it's a true honor and pleasure to be here at the time of the EAU meeting in Madrid.
Yes.
And share with you some insights on the journal and what's going on in the Congress so far.
Yeah, look, an amazing meeting. European Urology, always stars at these meetings. What's been the highlights of the EAU meeting so far for you?
Yeah, I think as compared to the previous years, I have noticed that the perspective of the meeting is much higher and much broader as compared to the previous years. Especially, for example, the topics of biomarkers in urologic oncology, the topics of multidisciplinary approaches and case-based debates are being increasingly discussed. And I think these are of true value for urologists because you really understand that your perspective has to be broad and has to embrace not only urology but also other fields, medical oncology, radiation oncology, and also translational research.
Yeah. And it's nice, isn't it, that these meetings are becoming so multidisciplinary. It's no longer just about the surgery. We are starting to understand more and more broader how to manage conditions.
Yeah, I think this is a major shift, a breakthrough in urology in general. We need to have a holistic mindset, I would say, and start with the disease rather than our specialty. Yeah. So if you start from the disease, you then understand that the perspectives are multiple and you need to manage them. Yeah. You need to acknowledge them, having the patient in front. So and also taking always insights from research. Yeah. I've not so much experience in translational research, but I enjoyed a lot, for example, the session on biomarkers, because you really appreciate how the field is moving. And also, if I may, had another session that caught my eyes, where the Lancet Plus European Urology session yesterday, in which three main topics, the burden of urological conditions, the future of urological surgery, and sustainability of care in urology were discussed. I think these are broad topics, but urologists must be aware of the changes in our world beyond our specialty.
Yeah, very good. And let's come back to the journal, European Urology Oncology, your associate editor. So this is a big meeting for you.
Yes.
Tell us about some of the things you love about being part of the journal.
Yeah, the journal is, I think, a tremendous opportunity, not only for me as a clinician, but also as a scientist, as a reviewer, as an editor. I think you learn a lot. The journal is very dynamic, and European Urology Oncology has a special character within the European Urology family of journals because it really embraces the urologic oncology scenario and perspective. And therefore, working for European Urology Oncology with you and the stellar team led by Professor Dupré is really a nice opportunity to have a 360-degree view on urologic oncology from the urological perspective, but also the oncology viewpoint. And I think this enriches you every day as a scientist, but also as a clinician.
Yeah. And what would your advice be to people out there who are looking to submit papers to the journal? What are the papers that ideally suit the journal? What do you like to see more of?
Thank you for this question, because it's important for the readership to understand the goal and the mission of the journal. The journal is multidisciplinary by definition, so the best suitable paper for European Urology Oncology has to be high quality for sure, because quality is the mainstay of the journal. We need to serve readers with high quality papers, and this is across, I would say, the topics. But then I would say that the topics with more chance of being multidisciplinary in the clinical messages are the ones that are more of value for the readership, meaning papers embracing diagnosis, staging, and the multidisciplinary approach to genitourinary cancers are the ones ones that I believe are more interesting for the broad readership of the journal.
Yeah, and it's important to keep that broadness through, isn't it? And especially now because we are understanding more and more about biomarker-driven treatment. Like you said, that wonderful session on biomarkers that you went to. This is becoming of more and more interest to urologists who typically did not see this to be a very interesting field.
Exactly. I think the journal has a mission in this regard to translate what's going on in the field of translational research back to the clinics and vice versa. And this is also important to show that a cultural change is needed now.
Yeah.
We need, as urologists, to be open-minded about research. We need to be updated. We need to acknowledge the guidelines view and how research is coming in the next years. And I think the journal has a major mission in this regard, and our mission as editors is really to serve the readers and to serve the urologists and the urologic oncology community at large, I would say.
Absolutely.
Really to guide this evolution, to understand the evolution, and to live with it together.
Yeah. Riccardo Campi, always a pleasure to chat with you.
It's a pleasure for me.
The only drawback in Madrid really is the weather. It's freezing cold, there's a lot of rain. Things are no better in Florence, I hear.
No, not in Florence in the past weeks, but fortunately everything should be fine now.
The time you get back.
But at least we have the chance to stay in the Congress, I would say.
That's true.
and enjoy the meeting and everything that offers to urologists and to the community. Thank you, Renu, very much.
Enjoy the rest of the meeting.
Thank you.
I'm here with Roderick Vandenberg. Rod, great to see you, old friend.
Likewise, Declan. Thanks for having me.
Yeah, so we go back a while. Roderick did a fellowship in Melbourne back in
2015, 2016.
10
Seems
years
like ages ago, but
ago.
I really was there.
You're aging well.
Thank you very much, Declan.
So we've dragged Roderick on the podcast. Where are you now? You're at NKI? You moved your position, didn't
I moved to Erasmus MC in Rotterdam,
Yeah,
so
Erasmus,
I'm
of
with
course, yes.
Monique and running the screening
Monique
trial.
Rubal. Back where you came from. You did your PhD
I did my
with
PhD there, back to my roots.
Yeah, back to Erasmus. So Rod's a urologist at Erasmus, but he's just stepped off the plenary stage here. He was the discussant in the practice-changing plenary about the NEUROSAFE trial. Now, we've already posted a podcast completely about the NEUROSAFE trial that posted this morning. We had it all lined up to post with the plenary and with the Lancet Oncology paper. And Rod, your task was to be the discussant on this. And so I was very interested. I was in the front row listening to your talk. And discussant is, supposed to be a little bit critical or provocative. And all. I thought you were very fair and balanced. But I'll first of all summarize a little bit about the NEUROSAFE study for those who haven't seen the podcast or read the paper yet. And then you can give us your thoughts. So this was a randomized control trial from the UK for patients undergoing radical prostatectomy for prostate cancer. They all had good sexual function, and the randomization was nerve sparing as planned by the institutional standard of care, so trying to avoid positive surgical margins and so forth, or nerve sparing using the NEUROSAFE technique. This technique whereby patients have a frozen section intraoperatively to assess the margins. The idea being that it might lead to increased rates of nerve sparing surgery, and that might lead to a better sexual function for patients. And in summary, it was a positive trial. It was a positive trial. They met their primary endpoint, which was improved sexual function at 1 year, and it was due to the fact that nerve sparing rates went from about 50% up to 85% or something. So very interesting. Conclusion was that this is the first randomized trial of radical prostatectomy to show that a technique change can lead to better sexual function. What are your thoughts, Roderick?
I did have some issues. So I've been working on the EU prostate cancer guidelines for a few years. We did a review 3 years ago. It summarized all the evidence there is on nerve sparing, and it was a bit disappointing for me, actually. I think it's a very commonly performed procedure. It's very important to many urologists, but the level of evidence for many of the trials around there is pretty poor, actually. So any high level of evidence addition to this field is important. So I congratulated them, of course, on doing the trial, getting it through 2 waves of COVID. It's important, but I did have some issues. And my first issue was the potential expectation bias. So it was a blinded trial officially, meaning that the participants were not aware whether they were in the standard of care arm or the NEUROSAFE arm.
In other words, they had a certain amount of nerve sparing, or they might have had increased nerve sparing. They didn't know that after the surgery.
No, but they were aware whether they received nerve sparing, yes or no.
Yeah.
And if you use patient-reported outcomes as your endpoint, and you are aware of the fact whether you had that treatment, yes or no. For me, it's less important whether it was achieved after NeuroSafe or achieved after the standard of care. So I think that expectation bias cannot be ruled out. That doesn't mean that the real results cannot be used, but I think we should be aware of this bias. That was my main point, actually. I had some other points.
Can I ask you about that again? So on the expectation bias, so the patients underwent either standard nerve sparing or they had the NeuroSafe. So half the patients got more nerves preserved, but they weren't aware of that. You know who's just walked into the background? It's the guy who did his PhD on the study. This is the way it is on GUcast. His ears must have been burning, Roderick. Eoin Dinneen, come on over here. And good to see you, my friend. Come on in.
No, but participants were aware of the fact whether they had nerve sparing, yes or no.
But not whether they had more nerve sparing or not. Because I'm wondering about the expectation bias. I mean, when they answered the questions a year later about erectile function, they didn't know whether they were in the NeuroSafe arm or not, or did they? Because would that not null out the expectation bias?
They knew.
Okay,
they knew what arm they were in. But, and so
then that, it does open up the expectation bias. I hear
Roderick,
you.
thank you very much for your critique.
Yeah.
We love seeing critiques of our work, of this paper, but and I agree with all of your other comments, but the expectation bias that a man would respond more positively on patient-reported outcome measures 12 months following surgery about the strength of their erections based on the fact that they were told they had a nerve spare the day after or in the immediate aftermath. I don't buy it. I did those clinics, and the proof of the pudding in that is that 83% of men had bilateral nerve spares, but actually only a minority actually really recovered. So if there was genuinely an expectation bias, maybe 83% of men would have had some kind of recovery, but we didn't see that. That speaks to the fact that we've still got a long way to go to minimise sexual toxicity in radical prostatectomy. But that's a different story.
But since you're here, I would like to make 2 points here, because you planned the study to do it double-blinded, but the patient representatives changed it and unblinded this part so that they were aware of the level of nerve sparing. And I think we can agree that doing a double-blinded trial from a methodological point of view is always better. So I get your point, you saw these patients, but if this would have been a pharma trial with the placebo not being blinded or whatever, they would have burned it. So
I've got one comment to come back on that again, and again, I actually agree with that, but in this instance, Roderick, you would have had a single blinded study or no study at all. Because we did not. This is about the trial team, the clinical research team, knowing what arm the patient was in, or what group they were allocated to. But we just didn't have the funding to conceal. We're routine clinicians, research clinicians, and we order their PSAs, we order their next appointment, we have access to their operation notes, and we couldn't shield ourselves from that level of information, because that would be an extremely expensive endeavour, and this is an investigator-led study run by surgeons. We don't have the big pharma backing to create whole new IT systems to develop this. So it really was a case of it's single-blinded or no study at all, and I hope your audience, Declan, will appreciate the study as it is, and we'll take these comments on board. Yeah.
Oh, and Roderick made that point in his introduction earlier on, and here on the podcast about, overall the quality of evidence to support nerve sparing is low. There's a presumption, and it's a reasonable anatomical presumption, but this is probably at least a decent level of evidence to be contributing to the field. And my question to you and then to Roderick is, it's opening up this topic of intraoperative margin assessment. Now, it wasn't dealt with so much today, but we did on the podcast the fact that this still takes like an hour to do, and if we try to do this in Melbourne, it's just not going to happen. It's just not pragmatic. But there are these other new technologies. Here in the trade hall, we see confocal microscopy. The histolog machine's literally next door to us here, and these other techniques for trying to do something similar without the burden of frozen section and the time and so on. What's your thoughts on that? Do you think that the NeuroSafe, or even just generally interest in nerve sparing versus positive margins, will lead to a kind of a surge in interest in intraoperative margin assessment with other technologies, not with NeuroSafe?
Yes. The short answer is yes.
What do you think?
So I think we should be careful and wait for the long-term oncological endpoints first, before we really know that shaving next to this tumor is really, really safe. I think that all these new techniques are really interesting, but my point is that you're still looking at the wrong side of the tissue. You're looking at the prostate which has been already removed, and I think it should be perfect if we look in the body at the neurovascular bundle, use tracers, PSMA, whatever, to see if there's any tumor left. That would be the way to go. but well, I think it's very challenging.
Agreed. I've got two other points to say on that. I think we totally recognise the limitations of frozen sections, traditional frozen sections. We would have loved to have more sites from the UK involved in this study, and we would love to have more NeuroSafe performed at the 5 sites that did contribute, or the 4 other contributing sites. But the pathologists typically say they can't do that. So if these are technologies which will increase the access and democratise radical prostatectomy to an approach which we now know improves functional outcomes, then as a team we're fully on board for that. Now the only other thing I would say is that we published a paper on MRI for extraprostatic extension diagnosis in 2022, looking at a very similar patient cohort. And what we saw was that in some patients, on given site-specific extraprostatic extension, using their MRI, your radiologists, if you know them and they know you and you know your scans and you know your patient cohort, they will tell you that they have extraprostatic extension. And perhaps in those patients, that point stands to reason, which is that maybe don't start with an intrafascial on that side. But it's the patients in whom there's doubt, with good preoperative functional outcomes, who want to achieve that, and you can have that conversation with them. And our data now in the manuscript will help facilitate that conversation. I think that's where the money is at for in real-time margin assessment.
Roderick, finally, you did show some lovely pictures of you doing a NeuroSafe. So at Erasmus, since you moved there now, you have experience yourself. And tell us a bit about the pragmatic approach, or which patients do you use it for, and how long do you have to wait, etc., just to get a peek into the reality of NeuroSafe.
So we have been doing it actually in all our patients, but we are moving towards a situation now where we don't do it in a very low risk site, so it's a site-specific approach.
That's pragmatic,
and do it in the young guys with good preoperative erectile function, with like a suggestion of T3. I think these are the ideal candidates. There's also a group at the other side of the disease spectrum, very high risk, where whatever you do, you don't need to NeuroSafe. So I think in the low risk spectrum you can leave it out, and in the high-risk spectrum, and then there's a sweet spot of cases where you can do it. It takes about 45 minutes. We sometimes do a lymph node dissection in between, but I know your opinion about. Let's not get started there. And usually you do the anastomosis already. The risk of doing a re-resection is about 1 in 5. So usually you can just leave that anastomosis there.
And
you
can actually work around it, actually.
You can work around it. You can use your third arm to pull the bladder away. So I got used to it. I drink an extra coffee with the team, waiting for the results, and it's pretty relaxed.
I love it. Well, look, thank you, gentlemen, for joining us. Congrats again, and really nice discussion as well, Roderick. Good to see you, old friend.
Thanks, Declan.
Thanks.
That's all we have time for on this episode of GUcast. I hope you enjoyed part 1 of our EAU highlights. Thanks again to our gold partners, Bayer China, who support our conference highlights. We'll be back with part 2 of our EAU conference highlights very soon. We'll catch up with some great guests as usual, and watch out for our special walk around the trade hall looking at new robots with Ben Chalicum.